Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Picture the highest stakes scenario imaginable in a trauma bay. The double doors fly open, a patient rides an extremis, and you can practically hear the physiological clock just running out.
Absolutely. It's terrifying.
Right. Blood pressure is plummeting, your standard ATLS resuscitation is completely failing, and that margin between life and death is shrinking to absolute zero.
Yeah, you're out of standard options at that point.
Exactly. So today we are focusing on the ultimate, absolute last-ditch damage control procedure. We're talking about the emergency or, resuscitative thoracotomy.
It really is the most dramatic intervention we have in trauma surgery. I mean, it's a true razor's edge maneuver.
Yeah.
You're bypassing every standard protocol of gradual, stepwise care to directly access the thoracic cavity. Because, well, the alternative is immediate, irreversible death.
Okay, let's unpack this. Setting the stage, the tension in the room is palpable. You're the ED attending or the trauma surgeon standing at the foot of the bed, and your cognitive load is just maxed out.
Completely maxed.
But before you even think about picking up a scalpel, a quick reminder for you, the listener. Please note that this content is for reference only. You must always follow local guidelines in your clinical practice.
Very important point.
Yeah, so our mission today, using guidelines from EAST, the WTA, and the ERC, is to dive deep into the clinical realities. We want to distill the critical decision-making thresholds and the precise tactile steps of this procedure.
Right, because knowing the physical mechanics of the procedure, like how to actually cut, is only half the battle.
Sure.
Knowing the precise physiological and temporal thresholds of when to actually initiate it, and maybe more importantly, when to withhold it, is what separates a life-saving intervention from a totally futile exercise.
Exactly. I mean, if you commit a massive amount of resources, your primary operator, anesthesiologist, nurses, massive transfusion protocols, plus an entire OR to an unsalvageable patient, you are actively detrimental to the entire trauma system.
You're taking resources away from someone else who might survive.
Right, so you have to know if opening the chest is actually justified. And there is a stark division here based on the mechanism of injury, right? Penetrating versus blunt trauma.
Huge difference, night and day.
Yeah, penetrating thoracic trauma is the classic indication. It has the best survival rates, especially if you're dealing with an isolated penetrating cardiac injury. But blunt trauma.
The outcomes are notoriously abysmal.
Yeah, overall survival is often less than 3%.
This raises an important question, and it really comes down to the underlying pathophysiology. With penetrating trauma, particularly, say, a stab wound to the precordium, you often have a focused, reversible puncture.
Right, like a single hole.
Exactly. The heart is bleeding into the pericardial sac, causing tamponade. The muscle itself is largely healthy. The rest of the body's vascular bed is intact, but the pump is just being mechanically restricted.
It's choked off.
Yeah. So if you can rapidly relieve that pressure and plug the hole, the system can actually restart.
But with blunt trauma, we're talking about a completely different physical reality, aren't we?
Oh, entirely. A high-speed deceleration injury that causes traumatic arrest isn't just a localized leak, it is widespread, multi-system tissue destruction.
It's just massive energy transfer.
Right, you're dealing with massive shearing forces, ruptured great vessels, severe contusions to the myocardium, bilateral pulmonary contusions, and that's often combined with devastating traumatic brain injuries or completely shattered pelvic rings.
Wow.
The physiological reserve is just completely annihilated.
Which brings us to the golden rule of this procedure, right? Don't pump an empty heart.
Right. Never pump an empty heart.
If the patient's entire blood volume is, third space into their shattered pelvis or loss on the highway, cutting open their chest to squeeze an empty ventricle isn't going to generate any perfusion.
It's useless.
But how do you know in that literal split second if the heart is truly empty or just failing?
Well, that is where POCUS has completely revolutionized the threshold of action.
The ultrasound.
Exactly. If you drop an ultrasound probe on the chest during a traumatic arrest and see organized cardiac motion, it strongly supports proceeding with the thoracotomy.
Because it shows the muscle is still trying.
Right. It tells you the myocardium is still viable if you can just fix the underlying mechanical issue. Conversely, cardiac stands still without tamponade in a blunt trauma patient. That signals futility.
So you just stop.
Yeah, that specific finding usually prompts the termination of resuscitation.
Man, the timelines attached to these decisions are incredibly unforgiving. I was reading that for penetrating trauma, The hard stop for CPR duration is usually 10 to 15 minutes.
Usually, yeah.
But for blunt trauma, it's even tighter, like 5 to 10 minutes maximum.
I have to ask, why such rigid temporal cutoffs? I mean, why not 15 minutes for blunt trauma, too?
It's because of the ischemic tolerance of the brain combined with this profound metabolic debt the body is accumulating.
Okay.
In blunt trauma, because the physiological disruption is so systemic, the brain is usually hyperperfused long before the heart actually stops. Oh, wow. So the clock started way earlier.
Exactly. By the time they actually lose their pulse, the anoxic brain injury is already severe. So if you push past 10 minutes of CPR in a blunt trauma arrest, even if you miraculously restart the heart, the probability of neurologically intact survival just drops to 0.
That is heavy. Okay, so let's say the criteria are met. It's a penetrating injury. CPR has been ongoing for maybe 6 minutes. There were signs of life in the rig. And POCUS shows cardiac motion.
You're good to go.
The transition from decision to incision has to be instantaneous. How do you actually breach the chest without the rest of the resuscitation just, falling apart?
It requires extreme parallel processing by the whole team. The thoracotomy doesn't stop the rest of the primary survey. It happens alongside it.
Right.
So at the head of the bed, the airway team is securing the tube. And critically, they will often perform a right mainstem intubation on purpose.
Like that purpose. To intentionally collapse the left lung and just get it out of the primary operator's way?
Exactly. When you open that left chest, you want a totally clear visual and physical field down to the pericardium.
That makes a lot of sense.
Meanwhile, massive transfusion is running, and the operator is prepping the chest. And I use prepping very loosely here.
Yeah, I imagine you don't have time for a full sterile scrub.
Not at all. The mandate here is speed over sterility. You might splash some betadine or chlorhexidine on there, but you do not wait for it to dry. You don't wait for full sterile draping.
Right.
Infection is a complication for patients who actually survive the next 5 minutes. Death from exsanguination is immediate.
Wow, yeah. So let's talk about the physical reality of the incision itself. The standard approach is the left anterolateral thoracotomy in the 4th or 5th intercostal space.
Usually right along the inframammary fold for women or just below the nipple line for men.
Right. You make this massive curvilinear incision from the sternal border all the way to the posterior axillary line. But wait, in the absolute chaos of a trauma bay, with blood pooling everywhere and the clock literally at 0, you're supposed to deepen this incision right along the superior border of the 6th rib.
Right, to avoid the neurovascular bundle.
Exactly. But how is that practically possible? I mean, you can't see anything in there.
You really can't see much, and that is exactly why you rely on tactile anatomy, not visual anatomy.
Okay.
You use the scalpel to get through the skin and subcutaneous fat, sure, but once you hit the muscle layer, you drop the knife and switch to heavy Mayo or Metzenbaum scissors.
You just push in with scissors.
You physically plunge your fingers into the wound, you feel for the hard ridge of the rib, locate its superior edge, and push the closed scissors through the intercostal muscles just above that bone.
Because the neurovascular bundle runs along the inferior groove of the rib above it. So if you cut high in the intercostal space, you slice the artery and create an iatrogenic hemorrhage that you now have to deal with on top of everything else.
Which is the last thing you need. So you pop into the pleural space under direct tactile control to ensure you don't lacerate the underlying lung. And then you just sweep the scissors posteriorly to open the chest wall.
Got it. And then comes the Finochiodo rib spreader. And the guidelines note a highly specific mechanical detail here. You must insert the spreader with the heavy rack and handle pointing downwards towards the axilla.
Yes, that is crucial.
But why is that orientation so critical? I mean, in the heat of the moment, does it really matter which way the handle points?
It matters immensely because it preserves your operational flexibility.
How so?
If you place the handle medially, pointing toward the sternum, that huge metal bar physically blocks the midline.
Oh, I see.
So if you suddenly realize the trajectory of the bullet actually crossed the mediastinum and the bleeding is coming from the right side of the heart, you are trapped.
Because the retractor is in your way.
Exactly. But by pointing the handle laterally toward the axilla, the sternum remains completely unobstructed.
So if you need to, you can immediately grab a giggly saw or heavy trauma shears, cut transversely right across the sternum, and extend your left thoracotomy into a massive bilateral clamshell.
Exactly.
Man, that foresight engineered into the instrument placement is just brilliant.
It really is. So the ribs are spread, the chest is open, you are scaring into the mediastinum. Your first target is addressing the immediate, reversible causes of arrest, starting with cardiac tamponade.
Here's where it gets really interesting. Because a pericardium filled with blood under pressure doesn't look like a normal anatomical diagram,
We're
right?
choosing close.
It looks tense, swollen, often bluish, or completely opaque. You have to decompress it. But you're supposed to identify the phrenic nerve first, which runs right down the lateral aspect of the pericardium. Again, I have to push back here. In a chest cavity filling with blood under terrible overhead ED lighting, are you really meticulously dissecting out a microscopic nerve?
Well, no, you aren't dissecting it, but you absolutely must identify its anatomical neighborhood.
Okay.
Because the phrenic nerve innervates the diaphragm. If you transect it, you paralyze that hemodiaphragm, severely crippling the patient's respiratory mechanics if they actually survive.
Right, which would be a disaster.
So you don't need to see the nerve perfectly, but you know its longitudinal path. So you grab the anterior pericardium with toothed forceps, specifically anterior to and parallel with where the nerve should be.
Oh.
You tent the tissue upward, make a small nick with scissors, and then extend that incision craniocaudally to create a large window.
And the moment you open it, the tamponade releases.
Oh.
The clot and blood evacuate, and you immediately plunge your hand in to palpate the myocardium and find the wound.
Yes. For a cardiac wound, your fastest, most effective tool is your index finger.
Just your finger.
Just your finger. Digital pressure controls the bleeding instantly. Once you have physical control, you can begin your repair, and the physics of the repair depend entirely on which chamber is injured.
Right, because the pressure dynamics are completely different depending on where you are. Like, if it's an atrial injury, the tissue is relatively tough, but the wall is thin and the pressure is low.
Exactly.
So simple running suture of, like 3,0 proline usually holds, but the ventricles are thick, highly muscular, and under massive pressure.
Oh, absolutely. If you try a simple running stitch on a lacerated left ventricle, the moment the heart regains a strong beat, the contracting muscle will literally tear itself apart against your suture line.
Oh, wow.
It acts like a cheese wire. So for ventricular wounds, you need horizontal mattress stitches to distribute the tension, and you absolutely must reinforce them with Teflon pledgets.
Oh, pledgets.
Yeah, little felt pads. That way the suture has something structural to bar against other than friable myocardium.
That makes total sense. But let's say you open the pericardium, there's no tamponade, but the heart is completely empty, or it's just weakly fibrillating.
Then you need to perform internal cardiac massage.
Right. And we know external closed chest CPR is terribly inefficient.
Yeah.
It might get you, 20% of normal cardiac output?
Around 20, 25%, yeah.
But direct internal massage can generate 60 to 70%. Why is there such a staggering difference in the physics of perfusion there?
It's because of how blood actually moves during CPR. Closed chest CPR relies heavily on the thoracic pump mechanism.
Go.
You are compressing the sternum to increase overall intrathoracic pressure, which squeezes blood out of the pulmonary bed and great vessels, combined with whatever direct compression of the heart you manage through the rib cage.
Right.
But when you open the chest, you completely abolish all negative intrathoracic pressure.
The vacuum is gone.
The vacuum is completely gone. You are now 100% reliant on direct mechanical squeeze of the ventricles. You have to physically encircle the heart between your two hands.
Both hands.
Yes. You use a bimanual clapping technique, compressing smoothly from the apex up towards the base to sequentially eject the blood into the aorta.
And you cannot use your fingers, right? You have to use the flat of your palms. What does a contused myocardium actually feel like? Because I imagine the instinct in a high-stress situation is to just squeeze tightly with your fingertips.
It is a fatal instinct, honestly. A contused ischemic myocardium feels incredibly boggy and friable. It has the consistency of wet tissue paper.
Wow.
If you press with the tips of your fingers instead of the broad, flat surface of your palms, your fingers will punch right through the ventricular wall.
Oh my gosh.
You will create a massive, unsalvageable iatrogenic rupture.
That is terrifying.
Okay.
So you're massaging bimanually, flat palms. And if the heart is in ventricular fibrillation, you have internal paddles ready.
Yep.
And because you were applying the shock directly to the wet myocardium, the impedance is practically zero, right? You bypass the skin, the ribs, the fat.
Exactly. So you only need a fraction of the energy, usually just 20 to 30 joules biphasic.
Yeah. Okay, so you shock them. But what happens when you've relieved the tamponade, you've sutured the hole, the heart is in a normal sinus rhythm. but the patient remains profoundly hypotensive, like the tank is simply too empty.
This leads to the third major maneuver of the procedure, aortic cross-clamping.
Clamping the descending thoracic aorta, you are isolating the largest artery in the body, deep in the chest cavity, surrounded by blood.
What's fascinating here is how we conceptualize the cross-clamp physiologically. It isn't just a clamp, it is a radical, desperate reallocation of whatever limited blood volume the patient has left.
Right.
By clamping the descending aorta just above the diaphragm, you are completely cutting off arterial blood supply to the entire abdomen, the pelvis, and the lower extremity.
You're deliberately making those organs ischemic.
Yes, you are sacrificing the gut, the liver, and the legs to force every remaining drop of blood to cycle exclusively between the heart and the brain.
It's just incredible.
It also serves as a massive tourniquet, temporizing any catastrophic infradiaphragmatic bleeding like a shattered liver or a torn iliac artery until you can transport the patient to the operating room.
But finding the aorta in a pool of blood has to be hazardous. It sits right next to the esophagus.
And you absolutely do not want to clamp the esophagus by mistake.
No, I imagine not.
The tactile trick here is to have the anesthesia team aggressively drop a thick orogastric tube down the esophagus early in the resuscitation.
Oh, that's smart.
Yeah, so when you plunge your hand deep into the mediastinum, you can physically feel the hard plastic tube. You know immediately that structure is the esophagus.
So you just push it away.
Exactly, you push it away, isolate the pulsatile muscular tube next to it, and clamp the aorta with a large DeBakey or Satinsky clamp.
All right, so you've clamped the aorta. The brain is getting whatever blood is left. The heart is beating. But the tank is still emptying because you have, say, a shattered, lacerated lung dumping blood into the chest cavity.
A nightmare scenario.
Yeah. You can't transport them like this. How do you plug a leak that massive, especially if it's central, and you can't just staple a wedge off the edge of the lung?
For that, you have to perform an extreme maneuver called the pulmonary Hiller twist.
So what does this all mean mechanically? How do you twist a lung?
Think of the lung not as a solid organ, but as a balloon attached to a thick neck. The hilum, which contains the main pulmonary artery, the pulmonary veins, and the bronchus.
Okay.
If there is catastrophic bleeding deep in the lung parenchyma that you cannot isolate, you surgically mobilize the pulmonary ligament to free the lower lobe. You then grab the entire lung and physically rotate it 180 or even 360 degrees around its own root.
Wait, you are literally twisting the neck of the balloon to kink off the plumbing.
It is aggressively mechanical. By kinking that pedicle, you instantly occlude the massive inflow of the pulmonary artery and the outflow of the pulmonary veins. The bleeding stops immediately. Now, this prolonged total ischemia means that lung will likely die. The patient will almost certainly require a pneumonectomy, the permanent removal of that lung once they get to the main OR.
But again, you are trading a lung for the patient's life in that exact second.
Exactly.
It perfectly encapsulates the entire ethos of damage control surgery. Stop the bleeding, restore perfusion to the brain, and get out. Which brings us to the exit strategy.
Right.
You've achieved a rhythm, the aorta is clamped, the major bleeding is mechanically halted. How do you transition this patient out of the ED? Because you certainly aren't sitting there doing a meticulous multi-layer cosmetic closure of the chest wall.
Oh, not at all. The chest is essentially packed with surgical laparotomy pads, large chest drains are thrown in, and the skin is pulled together. You quite literally use sharp towel clips to just clamp the skin edges tightly together to temporarily seal the wound.
Wait, you just clamp the skin with towel clips?
Literally just towel clips, yeah.
It really highlights how raw this phase of care is.
Yeah. If we connect this to the bigger picture, the ED thoracotomy is merely a bridge. The trauma bay is where you stop the patient from dying in that specific minute. But the real victory, the actual survival, is won in the operating room and the intensive care unit.
Because even if you fix the structural plumbing, the patient's internal biochemistry is completely collapsing.
Right, they have endured profound hemorrhagic shock, and they are deep into the lethal triad of trauma.
Let's break that down for the listeners, because the lethal triad, coagulopathy, acidosis, and hypothermia, isn't just a list of bad symptoms. It is a vicious, self-feeding biochemical cycle, isn't it?
It is a physiological death spiral. Due to massive blood loss and just being exposed in the trauma bay, the patient becomes profoundly hypothermic.
Right.
At low temperatures, the enzymatic reactions required for the coagulation cascade slow down exponentially. Platelets refuse to aggregate.
So their blood physically cannot clot.
Right, and simultaneously, because their tissues have been starved of oxygen for so long, their cells have switched to anaerobic metabolism.
Pumping out lactic acid.
Massive amounts of lactic acid. This severe acidosis physically changes the pH of the blood, which actually alters the three-dimensional shape of the serine proteases in the clotting cascade, rendering them completely useless.
Wow. So you can pour all the packed red blood cells and fresh frozen plasma you want into their central lines, but if they are cold and acidotic, those clotting factors are basically just expensive water.
Exactly. The immediate postoperative goal in the ICU is not fixing broken bones. It is the aggressive, targeted reversal of that lethal triad.
Rewarming them, fixing the pH.
Rewarming the patient core, correcting the acid-base disaster, and giving targeted blood products until their biochemistry allows them to clot again. Only then, perhaps days later, do they go back to the OR for definitive reconstruction.
It is an absolute marathon that starts with a 50-yard dash.
That's a great way to put it.
So to summarize for you all listening, the resuscitative thoracotomy is an incredibly rare, brutal, but truly life-saving maneuver. It requires intimate anatomical knowledge under extreme sensory overload, decisive action, and flawless parallel team coordination.
Absolutely.
And knowing when not to do it, recognizing the physiological point of no return to save systemic resources, is just as vital as knowing how to properly twist a lung or clamp an aorta.
It is a procedure defined entirely by its extremes. And, it leaves me with a final thought regarding the future of trauma resuscitation.
Oh, yeah.
Consider the immense cognitive load required of a trauma leader in these moments. They have to synthesize elapsed CPR time, the specific kinetic mechanism of trauma, POCUS feeds, and rapidly deteriorating metabolic data into a split-second life-or-death decision to open a chest.
It's overwhelming.
It is. As our trauma bays become more technologically integrated, how might continuous AI-driven physiological monitoring eventually take that human hesitation out of this intense algorithmic decision?
That's fascinating.
Imagine a system that instantly integrates dynamic blood loss, ultrasound feeds, and real-time cellular metabolic data to objectively instantly signal the exact threshold of salvageability.
That is a profound thought to mull over. Taking the guesswork out of the most stressful minute in medicine. Well, thank you for walking us through the brutal, fascinating reality of this procedure.
My pleasure.
And to our medical listeners out in the field, if you found this deep dive valuable for your clinical knowledge, please don't forget to share it with at least one of your colleagues or friends to help spread the word. Also, be sure to check out our YouTube and other social media pages. And if you're looking for more, do check our previous season and episodes. We've got some very relevant topics you won't want to miss.
Definitely check those out.
When you're standing in the trauma bay and that patient rolls through the doors, just remember, the stopwatch is always running. Trust your tactile anatomy, be decisive, and never pump an empty heart. Keep diving deep, and we will catch you next time.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.